welcome to the Deep Dive. You sent us a stack of sources tackling some incredibly complex, really important medical topics.
Yeah, deep stuff.
Specifically, looking at how we understand and predict outcomes in conditions affecting the brain, everything from coma states right through to the many phases of dementia.
That's right. These sources cover a huge range, really, from the very immediate challenges like assessing consciousness right after an acute injury
Right?
to the much longer-term, often progressive changes we see in neurodegenerative diseases. They get into the latest diagnostics, genetics.
And even touch on some big questions about consciousness itself.
They really do.
Exactly. You wanted to go deep, cover everything, really master this material like an expert. That's our mission for this deep dive.
Let's do it.
So, okay, let's unpack this stack of information. Let's see what vital nuggets of knowledge we can extract for you. We're going to start by looking at how doctors approach prognosis, especially in coma, before we dive into that vast and complex world of dementia.
Sounds good. And what's fascinating right from the start, I think, is just how challenging prognosis can be right after a severe brain injury.
Yeah.
The sources really emphasize that uncertainty early on.
The sources kick off right there, highlighting exactly how tricky this is. We see that some patients, particularly, children and young adults, can have really ominous early signs. Things like abnormal brainstem reflexes, which sound, frankly, terrifying.
They do.
And yet, despite those signs, they can still recover.
It's remarkable.
So because of this, early prognostication outside of, confirmed brain death, well, it's really advised against. You just can't jump to conclusions too quickly.
That's a critical point. The source material absolutely reinforces that. Trying to make an early prediction is, well, unwise.
Right.
And it's not just about the severity of the injury itself. The underlying cause matters tremendously.
Oh.
For instance, metabolic comas, where the brain's affected by systemic things like blood sugar or electrolytes.
Right, body chemistry stuff.
Exactly. They often have a much better prognosis than comas caused by direct trauma to the brain. The fundamental reason for the coma really changes the likely path forward.
So it's definitely not a one-size-fits-all picture.
Not at all.
For adults, while there are systems, to estimate prognosis, they're really just approximations. The material makes it clear we need to temper those predictions. You have to consider other factors unique to that person, their age, any other underlying diseases they might have.
Their overall health.
Exactly, their general medical condition. Prognosis isn't just about the brain injury in isolation, it's about the whole patient.
Precisely. The Glasgow Coma Scale gets a mention.
Right, I saw that.
As a tool specifically designed for collecting prognostic info, especially with large numbers of head injury patients.
Standardizing things.
Yeah, it standardizes assessment, which is essential for collecting data, approximating outcomes across groups. It has real predictive value in those cases, but again, it's a group predictor. Needs individual context.
What about comas specifically from lack of oxygen, like after a cardiac arrest? The sources mentioned certain signs are particularly important there.
Yes, absolutely. For anoxic coma caused by that oxygen deprivation, clinical signs are key.
Right.
Things like pupillary responses, how the eyes react to light and motor responses, any movement or lack thereof, those are monitored very closely.
Okay.
Their state after 1 day, 3 days, even up to a week can have predictive value.
But there's a complication.
Well, yes, this is where modern critical care complicates things a bit, because therapeutic hypothermia cooling the patient's body is often used now.
Right, to protect the brain.
Exactly. But the text notes that some traditional prediction rules based on those clinical signs are less reliable in this setting. The hypothermia itself can affect reflexes and responses.
Ah, so the therapy designed to help can actually make assessing the state harder. What do doctors do then?
Well, in that setting, with therapeutic hypothermia, the advice is serial examinations, repeated checks over time.
Keep looking.
And a multimodal prognostication approach, basically combining different assessment methods.
Like what?
The sources give an example, looking at the cortical responses of somatosensory evoked potentials, SIPs.
SAPs?
Yeah, these are electrical signals the brain generates in response to stimulation elsewhere, like a small electrical pulse on the wrist.
Okay.
The absence of certain SIP responses has been shown to be a very strong indicator of a poor outcome after hypoxic injury, even when patients are cooled.
So you combine SFPs with the clinical exams, maybe imaging.
Exactly. Gives a more robust picture than just one measure alone.
That brings us to states often associated with very poor outcomes, specifically the persistent vegetative and minimally conscious states.
Right.
The sources point out that while the prognosis historically was seen as uniformly poor, new reports are starting to alter that perception a bit.
Mm.
And here's where it gets, well, really interesting.
It truly does. The text highlights findings showing a small number of patients in these states displaying cortical activation, actual brain activity, picked up by functional MRI, fMRI.
In response to relevant stimuli. In one series they mention, about 10% of vegetative patients, mostly after trauma, could activate parts of their brain, like the frontal or temporal lobes, when asked to imagine certain tasks,
Imagine, like what?
like navigating a familiar place or playing tennis in their mind.
Wow. Imagining specific scenarios, showing complex brain activity, even though they couldn't move or speak or respond behaviorally.
Exactly.
And it's not just fMRI picking this up, right?
That's correct. Another series found that up to 15% of patients with various acute brain injuries who showed no behavioral response to motor commands like move your hand did show corresponding EEG activation.
EEG, the electrical activity.
Right, so EEG corroborated the fMRI findings. Both point towards some kind of covert cognitive processing capacity that isn't visible externally.
So evidence of brain activity suggesting some level of processing, even without observable behavior. But the sources are careful here, too.
They absolutely temper these findings. It's crucial to avoid making broad generalizations from these, initial studies.
Sure.
However, they fundamentally underscore a clear need for future research using these novel techniques, not just for diagnosis maybe, but potentially to help establish communication,
With these individuals.
potentially, and maybe even aid in their recovery. This raises a really important question for us to consider. What does this hidden brain activity truly represent in terms of consciousness?
Yeah.
And how might our understanding, even our approach, change as we find ways to harness that information? It really challenges our purely behavioral definitions of consciousness.
Definitely food for thought. Okay, let's pivot now from acute injury and coma to a condition affecting millions worldwide. Dementia.
Right.
Our sources describe dementia not as a single disease, but as a syndrome. Lots of different causes. It affects nearly 6 million people in the U.S. alone, with just a staggering annual healthcare cost. Over $300 billion. It's a massive health and economic challenge.
It really is. And at its core, dementia is defined as an acquired deterioration in cognitive abilities.
Acquired meaning it develops, you're not born with it. Exactly. It's a decline, and it's severe enough that it impairs the successful performance of activities of daily living.
Right. That impairment in daily life is the key threshold, isn't it? Separating it from just mild age-related changes.
That's the clinical threshold, yes.
And the first cognitive function that's most commonly lost.
That's typically episodic memory, our ability to recall specific events tied to a time and place.
Like what you had for breakfast or your last birthday party.
Precisely. The prevalence of clinically identifiable memory loss goes up significantly with age. About 10% over 70, maybe 20–40% over 85.
The likelihood increases.
Clearly. Though, as we'll get into, it's not seen as an inevitable part of normal aging for everyone.
Right. But dementia isn't just about losing memories. It can erode a whole range of other mental faculties.
That's absolutely right. It can affect language, visuospatial skills.
Like navigating or judging distances.
Exactly. Also, judgment, behavior, mood, attention. It's broad. And this often manifests as neuropsychiatric syndromes, changes in personality and behavior.
Like depression, apathy.
Right, apathy, that loss of motivation. Also, anxiety, hallucinations, delusions, agitation, sleep problems. A whole spectrum of symptoms, not just cognitive ones.
And the clinical course, how it progresses, can vary wildly depending on the underlying cause.
It really can. The tempo of decline is a crucial diagnostic clue. It might be slowly progressive over many years, which is typical for Alzheimer's, AD.
Oh, yeah.
It could be static, happens suddenly due to something like severe lack of oxygen, anoxic encephalopathy, and doesn't get significantly worse.
Right.
Or it might fluctuate dramatically, day to day, even minute to minute sometimes. That's characteristic of dementia with Lewy bodies, DLB.
Wow, that fluctuation must be hard to manage.
Extremely. The speed and pattern of decline tell doctors a lot.
And the initial symptoms aren't always the same, not always memory.
Correct. While most patients with AD, the most common form, do start with that episodic memory impairment. Other types, like frontotemporal dementia, FTD, are much less likely to present with memory loss first. FTD often starts with noticeable personality changes, behavioral issues, or problems with language.
Okay, so the sources explain these different clinical features arise from disruption of specific large-scale neuronal networks in the brain.
Yeah, think of it like interconnected
Like
circuits.
different sections of a city network talking to each other.
Good analogy. It's the specific location and the severity of the damage to these connections, the loss of synapses and neurons, that determines which symptoms appear.
So understanding the functional anatomy is essential for mastering this.
Absolutely. The sources touch on the role of ascending neurotransmitter pathways. These are like the brain's chemical messenger.
Dopamine, serotonin.
Exactly. Noradrenergic, serotonergic, dopaminergic pathways, they're heavily involved in modulating behavior, mood, attention. Cholinergic signaling is critical for attention and memory. And the specific neurotransmitter deficits, which pathways are hit, differ across the dementias. This helps explain the symptom clusters and guides pharmacological therapy.
Right. Knowing which system is down helps choose the right drug, potentially. And the anatomical spread of the disease matters hugely too. AD, for instance.
Typically begins in the interhinal region, a key hub deep in the medial temporal lobe.
Okay.
From there, it classically spreads to the hippocampus, vital for new memories, other limbic structures involved in emotion, and eventually out into wider areas of the temporal and parietal cortex.
Causing widespread degeneration.
Right. And this pattern directly aligns with its typical presentation. Memory loss first, then later, issues with language, executive function, navigation. It's like watching the disease march through specific brain regions.
But vascular dementia is different.
In contrast, yeah.
Yeah.
Vascular dementia isn't usually one spreading process. It's more about focal damage, little strokes, white matter damage in a patchwork of regions. It's disrupting communication between network nodes. And dementias, starting in the frontal or subcortical regions, like FTD or Huntington's,
Uh-huh.
are less likely to begin with memory problems. They're more likely to present with issues in judgment, mood, executive control, movement, behavior, because those are the functions those regions primarily handle.
The sources get quite specific about certain key circuits, like the frontal striatal pathway.
They do, because understanding these helps explain a range of common symptoms. Lesions, damage in these pathways have predictable effects.
That's just
Damage to the dorsolateral prefrontal cortex, outer upper front part, or its connection to the caudate nucleus.
deep brain structure.
Right. That can cause executive dysfunction, problems with planning, organizing, mental flexibility, working memory. Managing complex tasks breaks down.
Okay.
Damage to the lateral orbital frontal cortex, outer lower front part, or its connections. That can lead to impulsiveness, distractibility, disinhibition, trouble controlling behavior, saying inappropriate things. That system's key for social behavior.
And there's another one.
Yeah, interruption of the circuit involving the anterior cingulate cortex, medial prefrontal cortex, and the nucleus accumbens.
And different areas.
Right. That can result in apathy, that profound lack of motivation, poverty of speech, emotional blunting, even akinetic mutism, where someone's awake but unresponsive. That circuit's critical for drive and emotion.
And damage to other parts of these same loops can cause similar symptoms, like downstream effects.
Exactly. These corticostriatal systems also involve the globus pallidus and thalamus, other deep structures. Because they're all interconnected, damage to these nodes can reproduce the clinical syndrome associated with the cortical or striatal injuries.
So it's a whole circuit breaking down.
Right. And then involvement of brainstem nuclei, cerebellar structures that can further contribute to cognitive, behavioral, motor issues. It adds layers to the complex picture.
Okay, diving into the actual causes of dementia now. The single strongest risk factor, increasing age. The sources state that disabling memory loss increases with each decade over 50. And it's usually associated with those microscopic AD changes found at autopsy in older folks. Yet they point out some centenarians maintain completely intact memory. So whether dementia is an inevitable consequence of normal aging, that remains controversial.
That distinction is key. It's not a simple linear decline for everyone.
And what we often see, especially in older individuals, isn't just one thing causing it.
Right. Mixed pathology is very common. More than one type of damage contributing. Our sources specifically mention chronic traumatic encephalopathy, CTE.
From repetitive head impacts.
Exactly. Athletes, military veterans. It's a distinct proteinopathy, abnormal protein aggregation, presenting with cognitive, mood, behavior, or motor changes. Distinct from AD, though they can overlap.
What about patients who develop dementia younger, say under 65?
In that younger group, frontotemporal dementia, FTD, actually rivals AD as the most common cause.
Really?
And importantly, chronic intoxications, long-term heavy alcohol use, even certain prescription drugs are also an important and often treatable cause. Identifying those is critical.
Treatable is key. Which brings us to that crucial distinction.
Yeah.
Reversible versus irreversible causes. The sources provide a really comprehensive list.
Yeah, that table is vital for differential diagnosis. The hope, of course, is that with effective treatments for the neurodegenerative conditions themselves, this dichotomy might become less rigid over time.
Right.
But the text notes a really important study from a memory clinic, 1,000 patients, where 19% had a potentially reversible cause identified, and another 23% had a potentially reversible concomitant condition contributing.
Wow, that's a significant number, nearly 1 in 5 with a potentially reversible primary cause.
Exactly. Identifying and treating these factors could make a real difference for a substantial number of people.
So what were the most common potentially reversible culprits in that study?
The top three were depression, normal pressure, hydrocephalus and pH, that excess fluid issue, and alcohol dependence. Medication side effects are also highlighted as incredibly common, always something to consider.
What else is on that list?
It's quite broad. Vitamin deficiencies B1, B12, nicotinic acid, endocrine issues, thyroid, adrenal problems, chronic infections, HIV, neurosyphilis, certain head trauma outcomes, subdural hematoma, postanoxia, intracranial hypotension, brain tumors, autoimmune encephalopathy.
Immune system attacking the brain.
Right. Heavy metals, toxins, and even severe psychiatric conditions like depression or schizophrenia presenting with cognitive symptoms. It's a wide net, but crucial because treatment can help.
The sources also mentioned rapidly progressive dementia, RPD.
Yes, RPD is defined by that very fast tempo symptoms to dementia within a year or less.
Okay.
While Creutzfeldt-Jakob disease, CJD, the prion disease, is the classic example, especially with myoclonus, those muscle jerks. RPD cases are actually more often due to rapidly worsening AD, other neurodegenerative disorders, or importantly, autoimmune encephalitis.
Again, the autoimmune connection.
Yes, the sources highlight the rapidly expanding spectrum of these autoimmune causes for RPD. Antibodies attacking brain proteins like LGI1, Caspr2, NMDA receptor, AMPA receptor.
And recognizing these is critical. Why?
Because they're often treatable with immunotherapy, a potentially reversible cause of rapid decline.
Okay. Now, our sources also address the common experience of, simple memory slips as we get older.
Right, the senior moments.
They call subtle cumulative decline in episodic memory a common part of aging, historically termed benign forgetfulness of the elderly, meaning not serious enough to impair daily function.
Right. Though the distinction between benign and significant memory loss can be subtle, the text gives a pretty sobering statistic. At age 85, the average person recalls about half the items on a list learning task compared to when they were 18.
Wow. So some decline is common, but significant loss isn't necessarily benign.
Exactly.
And the progression towards what might become dementia is often described in stages leading up to it.
It is. There's a recognized pathway, sort of. Subjective cognitive decline is when someone feels their memory is slipping, but objective tests are still normal for their age and education.
So it's just a feeling at that point.
A subjective concern, yes. Then there's mild cognitive impairment, MCI. This is where there is a decline confirmed on objective testing.
Okay.
But crucially, it does not disrupt normal daily activities. They can still manage finances, appointments, etc.
And MCI isn't just one thing. It can look different.
No, it can be subcategorized. Based on the main deficit, you might have amnesic MCI, mostly memory problems, or executive MCI, mostly planning, organization issues.
Okay. And the sources list factors that predict progression from MCI specifically to AD dementia.
Yes, several predictors. Having a prominent memory deficit on testing is a big one. Family history of dementia. Genetically, having an ApoE4 allele.
The susceptibility gene.
Right. On brain scans, small hippocampal volumes, or an AD-like pattern of cortical atrophy, brain shrinkage. In cerebrospinal fluid, CSF, low levels of amyloid beta protein and elevated levels of tau protein.
Biomarkers in the spinal fluid.
Exactly. And modern PET imaging showing evidence of amyloid and tau buildup in the brain. These are all basically biomarkers reflecting the underlying AD pathology before frank dementia develops.
So to really master this, we need to understand what's happening at the molecular level.
Absolutely. The sources provide a table that really drills down into the core pathology of the major degenerative dementias, summarizes their molecular underpinnings.
And the common thread.
The common thread is the abnormal aggregation, the clumping up of a specific protein in the brain. This seems to be the engine driving the degeneration in many cases.
Okay, let's break down that table, starting with Alzheimer's disease, AD.
AD is associated with two main proteins misbehaving, amyloid beta, or A, and tau. There are rare causal genes mutations that pretty much guarantee early onset AD, like APP, PS1, PS2, but these are uncommon, less than 2% of cases.
So mostly not those specific genes.
Right. The much more common factor is the key susceptibility gene, ApoE4. Having copies increases risk significantly, but doesn't guarantee it.
And the physical evidence in the brain.
Amyloid plaques, neurofibrillary tangles made of tau, and neuropil threads. Those are the hallmarks.
And for frontotemporal dementia, FTD.
FTD is more varied molecularly. It can be associated with tau aggregation, but different forms than AD or TDP43, or even FET proteins.
So different proteins involved.
Exactly. For tau-related FTD, mutations in the MAPT gene cause about 10% of familial cases. Pathology shows tau inclusions in neurons and glial cells.
What about the TDP43 and FE types?
TDP43-related FTD involves genes like GRN, C9orf72, which is a major one, also linked to ALS.
Lou Gehrig's disease.
Right. Shows how the same molecular problem can cause different syndromes. Pathology is TDP43 inclusion. FET-related FTD is very rare, involves the FUS gene, FE2 inclusion. So FTD is really a family of diseases.
Okay. Dementia with Lewy bodies, DLB.
DLB is associated with alpha-synuclein aggregation.
Same protein as Parkinson's.
The very same, which helps explain the overlap in symptoms Parkinsonism hallucinations. A very rare causal gene is SNCA. Pathology shows alpha-synuclein inclusions called Lewy bodies. Their distribution differs between DLB and Parkinson's, affecting symptom onset.
Got it. Finally, Creutzfeldt-Jakob disease, CJD, the prion disease.
CJD involves misfolded prion protein, PRPSC. Prions are unique misfolded proteins that induce normal ones to misfold too.
That's how they spread.
Can be transmissible, though most human CJD is sporadic. The causal gene is PRNP, up to 15% carry mutations. A key susceptibility factor is homozygosity at codon 129 in the prion protein. Pathology is PRPSC deposition and that characteristic spongiosis brain tissue looking like a sponge.
And Huntington's disease,
Yeah,
also degenerative.
correct.
Right.
Caused by a specific mutation and expanded CAG repeat in the Huntington gene. Leads to abnormal Huntington protein aggregation, mainly in the basal ganglia. Causes movement disorders, psychiatric symptoms, and eventually dementia. Another protein problem linked to a genetic cause.
Okay. Beyond genetics and specific disease mechanisms, our sources highlight exposures and lifestyle factors across the lifespan that influence dementia risk.
Yeah, this is crucial. The modifiable risk factors
Like what?
includes things like low education, hearing loss, traumatic brain injury, midlife vascular risks like hypertension, diabetes, obesity, also heavy alcohol use, smoking, depression, physical inactivity, even air pollution.
And managing some of these can actually help.
It seems so. It's interesting that better management of those midlife vascular risk factors is credited with a decreasing incidence of dementia observed in North America and Western Europe recently.
Wow, so public health and individual choices can make a difference.
Suggests they can have a real impact, yeah.
But the picture changes globally.
It absolutely does. Causes are influenced by the local health context. Vascular dementia is more common in Asia, higher rates of intracranial atherosclerosis.
Narrowing of brain arteries.
Right. It's also rising in developing countries as vascular risk factors spread. And CNS infections, HIV, syphilis, cysticercosis, TB remain major contributors in many parts of the world.
And even recent events like the SARS-CoV-2 pandemic. Any connection?
Yes, the sources mention systemic SARS-CoV-2 infection might have lasting cognitive effects in some people.
Wow.
Possibly due to involving the brain's microvasculature, the tiny blood vessels, or maybe immunologically mediated white matter injury. Long-term prognosis is still unknown, but it shows how systemic insults can impact brain health.
The sources even draw insights from studying unique, isolated populations historically.
They do. Kuru, the prion disease links to cannibalism in New Guinea,
Right.
was instrumental in discovering human prion disease. The ALS Parkinsonism dementia complex of Guam, a polyproteinopathy involving tau, TDP43, alpha-synuclein, its incidence sharply declined, maybe due to environmental changes. Studying these rare groups has yielded profound clues.
Okay, the sources then shift to the practical approach.
Yeah.
How a doctor tackles a patient presenting with potential dementia. They emphasize three major issues to keep in mind. One, what's the clinical diagnosis? Two, is any component treatable or reversible? And three, how can we help alleviate the burden on caregivers?
Those are the guiding principles, exactly. And the patient's history is absolutely crucial here.
The kind of history details.
Onset, duration, tempo of symptoms. An acute or subacute onset, sudden or quick over days, weeks might suggest delirium, not dementia. triggering a search for intoxication, infection, metabolic issues,
Versus.
versus slowly progressive memory loss over years, much more typical of AD. The pace is a primary discriminator.
And the specific details of the history help point towards different types of dementia.
Absolutely. Specific early symptoms are strong clues. AD memory loss, difficulty managing money, FTD, personality change, disinhibition, compulsive eating, apathy, speech-language issues, DLB, early visual hallucinations, Parkinsonism, delirium, REM behavior disorder, Capgras syndrome.
Believing a loved one is an imposter.
Right. The initial presentation provides vital diagnostic clues.
A history of stroke or stepwise decline suggests vascular dementia. But there's a caveat.
Yes, the sources note many vascular dementia patients don't have that classic stepwise decline, and it's strongly associated with vascular risk factors: hypertension, AFib, smoking, diabetes. It can be hard to disentangle AD and vascular contributions when risks overlap.
Right. Rapid progression with rigidity and myoclonus strongly suggests CJD. Seizures could mean stroke, tumor, maybe early onset AD. Gait disturbance points to vascular PDDLB or NPH.
Exactly. Motor signs are key differentiators. History of high-risk behaviors. Check for CNS infections like HIV, syphilis, recurrent head trauma. Think subdural hematoma, CTE, NPH. And that subacute onset of severe amnesia and psychosis, especially with specific MRI findings, should raise concern for autoimmune encephalitis. Again, crucial to spot as potentially treatable.
The physical and neurologic exam adds more clues.
Vital clues. Complements the history. For instance, typical AD spares motor systems until late. FTD patients might develop axial rigidity, supranuclear gaze, palsy, even motor neuron disease. DLB often includes Parkinsonism, though cognitive hallucinatory symptoms can start earlier.
Okay.
The sources also mention less common ones: corticobasal syndrome, CBS, asymmetric rigidity, dystonia, alien limb, progressive supranuclear palsy, PSP, early falls, rigidity, vertical gaze problem.
Focal deficits, like weakness on one side.
Strongly suggests vascular dementia or tumor. Dementia plus myelopathy and peripheral neuropathy. Classic for B12 deficiency, though neuropathy has other causes. Signs of hypothyroidism. Look for them. Fluctuating confusion with stereotype movements. Might be non-convulsive seizures.
And even simple sensory loss can confuse things.
Yes, severe hearing or vision loss in the elderly can be misinterpreted as dementia. In younger patients, specific combos like hearing loss plus short stature could point to rare mitochondrial disorders. Thorough exam covers a wide range.
For objective cognitive assessment, brief screening tools like the MMSE or MOCA are common.
They are useful for capturing decline following progression.
But they have limits.
Yeah, the sources caution they aren't highly sensitive early on, nor reliable for discriminating between different dementia syndromes. Good starting point, but often not enough.
So you need more detailed testing.
Often, yes. A thorough neuropsychological testing battery, especially for MCI or early dementia.
What does that involve?
A series of tests assessing specific cognitive domains: memory working and episodic, executive function planning, problem solving, language, visuospatial skills, gives a comprehensive profile.
And the pattern of deficits helps differentiate.
Exactly. The pattern is key. Early AD deficits, typically in episodic memory, category generation, visual construction, FTD. Usually early deficits in executive control or language, though some have profound social-emotional issues not always caught by tests, PDD or DLB. More severe executive and visuospatial deficits, but relatively better episodic memory than AD at similar stage. Vascular dementia, often a mix of executive visuospatial deficits, prominent psychomotor slowing, delirium. Core deficit is attention, making other testing hard.
Beyond cognition, neuropsychiatric assessment is vital.
Absolutely crucial for diagnosis, prognosis, and treatment.
No.
Neuropsychiatric symptoms are often core features: early AD, mild depression, withdrawal, irritability, anxiety, later delusions, agitation, sleep issues. FTD, dramatic personality change, apathy, overeating, compulsions, disinhibition, loss of empathy early on. DLB, those visual hallucinations, delusions like Capgras, RBD, excessive sleepiness, dramatic fluctuations. Vascular dementia, depression, anxiety, delusions, disinhibition, apathy. Recognizing the pattern is as important as the cognitive profile.
What about lab tests? Seems like a balance between not missing reversible causes and low yield for individual tests.
It's a tailored approach. No single treatable cause is common, so screening needs multiple tests, each with maybe low yield. But missing a treatable cause is the bigger concern.
So you test anyway.
Generally, yes. Even tests with only 1–2% positive rate are often worth it. The American Academy of Neurology recommends a routine panel: blood count, electrolytes, glucose, kidney, liver, thyroid function, B12 level, and structural neuroimaging, MRI or CT.
Neuroimaging seems key. Structural first. What do MRI-CT help with?
Essential early on. Rule out mimics like tumors, locate strokes or inflammation, detect subdural hematomas, suggest NPH or white matter disease, and importantly, show regional atrophy patterns.
What kind of atrophy patterns are indicative?
Hippocampal atrophy plus posterior predominant cortical atrophy supports AD, focal frontal, insular, anterior temporal atrophy, suggests FTD. DLB often has less prominent atrophy, maybe more amygdala involvement than hippocampus. For CJD, MR diffusion-weighted imaging is often telling restricted diffusion in the cortex or basal ganglia. Extensive white matter abnormalities suggests vascular. MPH has specific features: hydrocephalus, crowded top, wide fissures despite minimal atrophy, dilated ventricles. Recognizing patterns is crucial.
The sources also mention functional imaging like SPECT and PET.
Yes, they can show hypoperfusion or hypometabolism patterns, temporal parietal in AD, frontotemporal in FTD, though MRI atrophy often corresponds.
And the newer PET scans, amyloid and tau.
Right. They directly visualize the protein pathology. Amyloid PET ligands bind to plaques, tau PET ligands bind to tangles in AD.
How are they used clinically?
Important point. Amyloid plaques are common even in cognitively normal older people, maybe 25% over 65.
So a positive scan doesn't automatically mean AD dementia.
Not necessarily. The main clinical value of a negative amyloid scan is to exclude AD as the likely cause. No amyloid. Probably something else.
And tau PET.
Tau spread is more tightly linked to cognitive state, so it's potentially more useful for ruling in AD and for staging severity, still evolving in clinical practice.
What about CSF analysis? Spinal fluid testing. When's that needed?
Lumbar puncture isn't routine, but indicated if sinus infection or inflammation are suspected.
But it can provide protein biomarkers too.
Yes, CSF levels of A42 and tau can show patterns. Low A42 or low A42-8 ratio, elevated total tau, and elevated phosphorylated tau are highly suggestive of AD pathology. Automated CSF assays are comparable to PE. Debate on routine use continues.
And blood tests for AD.
Promising area of research, aiming for less invasive detection, but still under development for routine clinical use.
Any other tests mentioned?
Formal psychometric testing, that detailed neuropsych testing, helps quantify severity, suggests psychological causes, track disease course. EEG isn't routine, but can suggest CJD, periodic complexes, or non-convulsive seizures. Brain biopsy, generally not advised unless suspecting vasculitis, tumor, unusual infection where diagnosis is uncertain. MR angiography if vasculitis or thrombosis suspected.
Okay, finally, treatment. Major goals seem clear. Treat reversible causes, provide comfort and support.
Absolutely. Addressing reversible causes first. Thyroid replacement, vitamin therapy, antimicrobials, antiretrovirals for HIV, shunting for NPH, treating tumors, and critically, reviewing and removing cognition-impairing drugs. Essential.
If a psychiatric disorder like depression is contributing.
Treat it vigorously. Even in degenerative diseases, comorbidities like depression or anxiety need treatment, often SSRIs or SNRIs with fewer cognitive side effects, anticonvulsants for seizures if they occur.
Behavioral problems, agitation, hallucinations, confusion sound particularly challenging. Major causes for institutionalization, the sources say.
Incredibly challenging.
Yeah.
And the sources stress a critical point. Before medication, aggressively seek out modifiable environmental or metabolic triggers.
The kind of triggers.
Simple things: hunger, thirst, meeting the toilet, pain, toothache, constipation, UTI, respiratory infection, electrolyte imbalance, drug toxicity. Easily correctable things that don't need psychoactive drugs.
And if drugs are needed for behavior.
Use caution. Avoid older drugs like phenothiazines, benzodiazepines due to side effects, even paradoxical agitation. Newer antipsychotics like quetiapine are sometimes used for severe agitation psychosis, but carry significant risks, including increased mortality in dementia patients. Escalating doses if things don't improve is often a mistake. Use selectively, carefully.
Are there drugs specifically targeting the dementia symptoms themselves?
Yes, symptomatic treatments. Cholinesterase inhibitors, donepezil, rivastigmine, galantamine used for AD, rivastigmine also for PDD. They boost acetylcholine.
Okay.
Memantine works differently on glutamate. Useful for moderate to severe AD. Main benefit seems to be reducing caregiver burden, maybe by reducing resistance to care. Some studies suggest combo therapy delays nursing home placement, others less clear. Caution with memantine and DLB can worsen agitation.
And the new frontier seems to be targeting those underlying proteins.
Correct. Therapies targeting production, aggregation, spread of amyloid, tau, alpha-synuclein. Aducanumab mentioned as the first amyloid-targeting drug approved for AD. Others target neuroinflammation, metabolism, synapses. It's where a lot of research is focused. Interestingly, sometimes cholinesterase inhibitors help neuropsychiatric symptoms too, especially in DLB.
Beyond drugs, managing the environment and routines is important.
Non-drug behavior therapy has a significant place. Goals: make life comfortable, uncomplicated, safe. Lists, schedules, calendars, labels help early on. Familiar routines, walks, simple exercise are useful. Let patients continue manageable hobbies. Use preserved abilities.
Must be hard for patients giving up controlled driving, finances.
Profoundly difficult. Attempts to help can be met with complaints, anger. Sources advise reassurance, distraction, calm, positive statements. Hostile responses are counterproductive. Eventually, tasks must be assumed by others. Patients can often adjust with support. Home safety modifications are crucial. Moving to a facility, initially confusing, need reassurance, reorientation.
And finally, the sources strongly emphasize supporting the caregivers.
This is vital. The toll is immense. Pay attention to caregiver frustration, depression, guilt, burnout. Very common.
Yeah.
They often feel overwhelmed, helpless. Encourage use of daycare, respite services, education, counseling are important. Support groups like the Alzheimer's Association provide invaluable help. Supporting the caregiver is essential for the patient's well-being, too.
We've certainly taken a deep dive here, really aimed to master this complex information. From coma prognosis, those surprising findings in vegetative states, to the multifaceted nature of dementia causes, anatomy, proteins, lifestyle,
All right.
through diagnosis, testing, management.
Yeah, understanding these conditions means appreciating that interplay of acute injury, chronic degeneration, genetics, environment, the brain's intricate wiring. We've seen how different diseases hitting different regions of proteins cause vastly different symptoms. Mastering this really requires integrating all those levels: clinical, anatomical, molecular, practical support.
And how, even with these tough conditions, there's hope in identifying reversible causes, developing new therapies, and crucially supporting both the person affected and those caring for them.
It really highlights how dynamic our understanding is, constantly evolving with new imaging, new therapies targeting the roots of disease.
So what does this all mean for you, our listener, who wanted to master this? It means appreciating the complexity, the need for a thorough, multimodal approach, and seeing how the science is evolving, connecting the symptoms you see to the brain changes happen underneath.
And this raises, I think, an important question to leave you with. Considering those findings about hidden brain activity in unresponsive states and our increasing grasp of brain networks and how disruptions change cognition, behavior, even awareness, how might our fundamental definition of consciousness, maybe even personhood, continue to evolve? And what new ethical considerations does that understanding bring? Something truly profound to think about as this field moves forward.
Absolutely. And something we might explore further down the line. We hope this deep dive has given you that solid foundation and the expert-level insights you were looking for on this incredibly important topic.